Hello and welcome to this mini gem. Will you just have a look at this abdo x-ray, a surgeon's view on dilated bowel loops? I'm sure this is a scenario that sounds familiar, and as a surgical registrar, I've been on both ends of the referral. And what I'd like to cover today are 4 points which I hope are of relevance for your day-to-day clinical activities. These are: who needs urgent surgical intervention? Who needs a CT and why? What are the features of ileus and obstruction? And why, as the surgical team, we ask certain things. I'd like you to imagine the scenario that you're asked to review an 80-year-old female who was a week following a DHS for a fractured neck of femur, with a background of ischemic heart disease and dementia, and who is yet to mobilise following her operation. She's currently taking codeine, furosemide and ramipril. The reason you've been asked to see her is a distended abdomen without any obvious pain, but her bowels haven't opened since the operation. You are handed over to chase the abdominal film, which looks like this. Take a second just to have a look at it. As you'll rightly see, there's gaseous distension of the small bowel, so you decide to ring the surgical team. The surgical registrar asks you, firstly, how are the groins? Secondly, do they have a tender abdomen? And thirdly, what do you find on digital rectal examination? You sigh and think, why are they being so awkward? Why indeed does it matter? What I'd like to share with you now is perhaps the other side of the story, as to what might be going through the surgical registrar's mind. From the way I see it, there are 3 main questions that need to be answered for any patient such as that in the case study. Ultimately, the questions that we ask you to help us answer these, and to prioritise our work. These questions are, firstly, do they need an immediate operation? Secondly, are they likely to be mechanically obstructed? And thirdly, if they're going to be conservatively managed, when should they be re-evaluated? Firstly, let us consider the first question, do they need an immediate operation? As ultimately, these are the patients that require life-saving intervention promptly. There are 4 main reasons that a patient with bowel dilatation would require urgent surgery, and these are perforation, bowel ischemia, cecal compromise, meaning pending cecal perforation, and a strangulated hernia. And please take a moment now to think about the clinical features of each of these. To start with the easy one, a strangulated hernia. This presents as a tender, irreducible swelling over a hernial orifice, such as a scar, the umbilicus, or the groins, and it's groins that are often missed. Note now, with the other 3, the single feature common to all of them is pain, and by this I mean tenderness on examination, which is often disproportionate. And all of this together makes it easy. Any patient with bowel dilatation, marked tenderness, or an irreducible hernia requires urgent surgical referral, as they potentially need urgent life-saving surgery. I'd like to take a second here to mention lactate and bowel ischemia. It seems to cause a lot of confusion in my experience. As I mentioned on the last slide, the first symptom of bowel ischemia is pain. This indicates that the gut is underperfused. It is true that lactate goes up in ischemic bowel, but similarly and importantly, a normal lactate does not exclude bowel ischemia, as in the early stages it may be normal. Similarly, the same can be said for CT, as radiological features of ischemic bowel are a late sign. Please keep a high index of suspicion for small bowel ischemia, and if there's any concern, refer immediately and do not delay for any investigations. Let us move on now to trying to distinguish who has a mechanical obstruction and who has an ileus. Whilst this can be challenging, there are several clinical features that may sway us one way or another. I would look at this twofold. Firstly, do they have risk factors for an ileus or a mechanical obstruction? And then secondly, which clinical features are there to support one diagnosis over the other? So let us start with risk factors. For our ileuses, often patients have electrolyte imbalance, immobility, and drugs such as opiates that may precipitate this. Conversely, patients with mechanical obstruction may have had previous surgery, previous episodes of obstruction, or have features compatible suspicious with malignancy, such as weight loss, rectal bleeding, or recent narrowing of the caliber of stools. So let us now think about the clinical features of an ileus compared to that of a mechanical obstruction. And to do this, we should consider what happens to the bowel in both. In an ileus, the bowel is hypomotile, and so peristalsis is decreased throughout the gut. This means that the patient shouldn't have pain caused by peristalsis, bowel sound should be sluggish, and often faeces will be present in the rectum on digital examination, as some is getting through, albeit slowly. Now contrast this with a mechanical obstruction. As you can imagine, peristalsis against an obstruction causes pain, hyperactive bowel sounds, and there shouldn't be faeces in the rectum unless they've been there a while, as there's no passage of gut content past the obstruction. So you may wonder what the importance is of making this distinction, and that's because it alters the prognosis and the management of the patient. An ileus is generally self-limiting, whereas mechanical obstruction often needs surgery to sort it out. If you suspect an ileus, the most important thing to do is identify any potential reversible causes and treat these. You can then try using enemas, and then try a trial period of up to 48 hours of conservative management with regular clinical review, after which, if they haven't settled, a CT scan should be done to ensure that you aren't missing a mechanical obstruction. If the patient deteriorates at all, then they should be referred for surgical review. If mechanical obstruction is suspected, then they should be treated with the drip and suck approach that I'm sure we're all familiar with, that involves a drainage NG tube, a catheter, intravenous fluid therapy, SIPs orally, and a CT scan to determine the cause of the mechanical obstruction, as this will determine whether or not they need surgery and how they should best be managed. I'd like now to make one last point regarding the colon: isolated colonic distension. Sigmoid volvulus may cause painless colonic obstruction, which still needs urgent referral, and this can be identified from an abdominal X-ray. If the patient has a dilated colon but doesn't obviously have a volvulus, then I would have a very low threshold to do a CT scan, as in these patients it's very difficult to distinguish between a pseudo-obstruction in the distal colon or a diverticular or malignant stricture causing insidious progressive obstruction. If you find that their colonic distension is due to pseudo-obstruction following imaging, then they need surgical referral if they have any signs of respiratory or renal tract compromise, as colonic decompression may help with this. Let us now return to the case that we mentioned earlier and compare two scenarios. Firstly, you go and review the patient. She has no pain or hernias. There's some soft stool in the rectum, and so you think that this is most likely in keeping with an ileus. So what do? I think in this case it's reasonable to plan 48 hours of conservative treatment with reversal of risk factors and regular clinical review with surgical referral if there's any deterioration or pain. Now let us consider another situation where you review the patient. She has colicky pain but no tenderness, but there's a hard lump in the groin. What would you do now? I think in this situation, urgent surgical referral. Don't delay this for a CT. So to summarise what we've covered, whilst there are many different causes for bowel dilatation on an X-ray, the ward-based management of them is relatively simple and follows the following patterns. If the patient has tenderness or an irreducible hernia, they need immediate surgical review and do not delay this for imaging. In other patients, try to predict whether you feel they have an ileus or a mechanical obstruction. If you think an ileus, then they need the risk factors reversing and a period of observation, and then a CT if it doesn't settle. If you think they have mechanical obstruction, they need a CT scan and surgical review. And finally, remember, if you're uncomfortable making a decision or feel like the patient is deteriorating, then just refer the patient. Thank you.